If you've been told that you have anterolisthesis, then you're probably stuck in the worst possible place. Not bad enough for surgery, but too unstable for anyone to treat. Here's what almost no one tells you. Many of those decisions are made without measuring how unstable your spine actually is when you move. I've spent over 30 years working with complex spinal cases, and in this video, I'll show you how a non-surgical corrective care plan is designed using motion-based x-rays, how specialized RoboTrack traction for anterolisthesis correction can help reduce a forward slip vertebrae, and how one of our patients reduced their anterolisthesis and avoided fusion surgery entirely. If you've been told to wait and see, or have been recommended back surgery, keep watching. Missing even one part of this video could be the reason why your anterolisthesis symptoms continue to progress instead of stabilize. I'm Dr. Jenkins, a corrective care chiropractor in Kelowna, British Columbia. I help patients restore their health, mobility, and confidence through advanced, non-surgical spinal rehabilitation. I'm one of only a few doctors in the world who are advanced certified in chiropractic biophysics, and one of just 2 advanced certified clinics in the entire west coast of Canada. My mission is simple: to help people live strong, active, and pain-free lives for as long as possible. I do that by focusing on real correction, not just pain relief, helping people fix the root cause of spinal problems that have held them back for years. On this channel, you'll find clear, evidence-based videos that explain how your spine and nervous system work, why posture matters, and what you can do to move and feel better naturally. So if you're ready to take control of your health and start moving without fear again, subscribe to the channel. You'll discover practical, evidence-based ways to correct your posture, protect your spine, and keep your body strong for life. I upload a new video every week. If you've been diagnosed with anterolisthesis, the most frustrating part is not just the pain, it's the uncertainty. You're told it's not severe enough to justify surgery yet, but at the same time, you're warned that it's too unstable for most conservative care. So you're left waiting, watching your symptoms, being careful with every movement, and quietly wondering if you're making things worse without realizing it. For many people, the hardest part is that nothing feels definitive. Some days you can walk. Other days your legs feel heavy or weak after 10 or 15 minutes. You start avoiding long outings, standing in lines, even simple errands, not because you want to, but because your body no longer feels predictable. And yet, when you ask what to do next, the answer is often vague. Wait and see, strengthen your core, avoid certain movements, come back if it gets worse. This is what I call the surgery gap. It's the space where people live for months or even years, not because nothing can be done, but because no one has clearly explained what actually determines risk and progression in anterolisthesis. The assumption becomes that time will give clarity. In reality, time often just increases fear. What most people don't realize is that being in this gap does not automatically mean surgery is inevitable. It often means the spine has not been properly evaluated in the way that actually matters. Decisions are being made without understanding how that slipped vertebrae behaves when you move, load, and walk. Without that information, both patients and providers default to caution, and caution turns into inaction. To move forward safely, we have to change the conversation. We have to stop talking only about what a still image shows and start talking about what your spine is actually doing. Because once you understand that difference, the path forward becomes much clearer. And that starts with understanding what anterolisthesis really is and what it is not. When people hear the word anterolisthesis, the mental image is usually the same. A vertebrae has slipped forward, so the spine must be unstable, fragile, or damaged. That assumption creates fear. But it is not the full story. A forward slip sounds dramatic, yet the presence of a slip alone does not tell us how risky or how manageable the condition actually is. Anterolisthesis usually develops slowly over time. Disc wear, posture changes, and repeated loading gradually allow one vertebrae to shift forward. It's rarely caused by one wrong movement. And just as importantly, a spine with a slip is not automatically collapsing or failing. Many people live with a stable anterolisthesis for years without making their symptoms worse. Others struggle despite having what looks like a small slip on imaging. The difference comes down to movement, not appearance. See, a single X-ray or MRI taken while you're lying still can show that a slip exists, but it cannot show how the vertebrae behaves when you bend forward, extend backwards, stand upright, or walk. Risk is not determined by what the spine looks like at rest. It's determined by how much one vertebrae shifts relative to another during motion and load. This is why flexion, extension, lumbar x-rays matter. By imaging the spine while you bend forward and backward, we can see whether that vertebrae is actually translating excessively or whether it remains relatively controlled. These motion-based studies allow us to measure instability rather than assume it, which is something most patients have never had done. This is where so much confusion begins. The word unstable gets used as a label, not as a measurement. Without seeing how the spine moves, treatment decisions become educated guesses. Some spines that look alarmingly barely move at all. Others that appear modest on a static image shift excessively when the body is in motion. Without measuring that movement, both patients and clinicians are forced to assume the worst or avoid doing anything at all. Once we start measuring how the spine behaves during motion, everything changes. We can begin to separate fear from fact. We can understand whether the problem is true instability or excessive loading on an already irritated segment. And that distinction is what determines whether conservative care can be both safe and effective. From there, the question becomes how to reduce that stress safely before asking the spine to stabilize itself. It's important to say this clearly. When traditional conservative care falls short with anterolisthesis, it's not because those approaches are wrong or careless. They simply were not designed to create structural correction in a forward-slipped vertebrae. Most conservative care is built around pain relief, general strength, and symptom management, not targeted spinal realignment. For example, standard physiotherapy often focuses on flexion-based exercises, stretching, and core strengthening. These can be helpful for many back conditions, but they do not address the forward shift of the vertebrae itself. Strengthening muscles alone cannot change how the bones are stacked or how load is distributed through the disc and ligaments at that L4 or L5 segment. In some cases, these programs help symptoms temporarily, but the underlying mechanical stress always remains unchanged. The same is true for many hands-on treatments. Manual therapy, general chiropractic adjustments, or passive modalities may reduce tension and improve comfort, but they're not designed to guide a slipped vertebrae back towards a more neutral position to retrain the spine to hold that correction during movement. This is why many providers hesitate to treat anterolisthesis aggressively. Without a structural, corrective framework, the care becomes management rather than correction. Chiropractic biophysics is different. Even though it's still non-surgical and conservative, CBP is built specifically around research-based methods to correct global spinal misalignments, postural displacements, and localized vertebral slippage. Instead of focusing only on symptoms, it addresses how the spine is shaped, how it carries load, and how those mechanics influence nerve pressure and stability over time. That distinction is what allows a corrective care plan to target an anterolisthesis at L4 or L5 rather than simply work around it. And once you understand that difference, the next question becomes how that corrective approach is applied safely and progressively in real patients. That is where the non-surgical corrective care plan begins. Once we know how your spine actually moves, the next question is what to do with that information. This is where most people either get pushed forward towards surgery too early or handed generic care that was never designed to correct a forward slip vertebrae. What we use instead is a structured, non-surgical corrective care plan that follows a very specific sequence for both safety and effectiveness. Step 1 is the stress analysis. This is where digital stress x-rays are used, including flexion and extension x-rays. You bend forward and backward while the images are taken so we can measure exactly how much that vertebrae is moving under load. This step answers the most important question first. Is this something that can be managed conservatively, or is the instability truly beyond safe limits? We do not guess, and we do not treat blindly. This analysis determines if you are a good candidate for care and removes the tremendous amount of uncertainty. Step 2 is computerized unloading using RoboTrack. For patients who are in pain or dealing with nerve symptoms, the spine needs to be unloaded before it can be retrained. RoboTrack is not generic traction. It uses computer-controlled, repeatable traction that is specific to anterolisthesis correction. The goal is to gently reduce pressure on that forward slip disc and compressed nerves, allowing inflammation to calm down. This phase can also help create a vacuum effect within the disc, drawing fluids back in and improving the environment before any active correction is attempted. Step 3 is structural remodeling. Once symptoms are better controlled, the focus shifts to alignment. Using mirror image exercises and traction from chiropractic biophysics, the spine is guided in the opposite direction of the slip. This applies reverse loading to the area, encouraging the ligaments and supporting tissue to adapt and hold the vertebrae in a more neutral position. This step is about changing how forces move through the spine so the slip is no longer being driven forward with everyday movement. Step 4 is neurological lock-in. Structural changes do not last unless the nervous system learns how to control it. Sensory motor control exercises are introduced to retrain deep, stabilizing muscles and improve coordination. The goal is for stability to become automatic so you can walk, sit, and move without constantly guarding or worrying that the vertebrae is going to slide forward again. Correcting a significant spinal problem takes work, but the choice is easy when you compare it to the alternatives: losing leg function, developing bowel or bladder issues, or undergoing major fusion surgery with permanent hardware. Compared to a 6 to 12 month surgical recovery, this approach allows you to stay functional, sleep in your own bed, and progress while you continue to live your life. Even surgeons agree on this point. Orthopedic surgeons and neurosurgeons consistently state that surgery should be the last resort. If the people who perform these operations want you to avoid them whenever possible, then choosing a measured, non-surgical path first is the most logical decision you can make. Safety is built into every step. The initial stress analysis tells us whether or not to treat. RoboTrack improves safety by removing human force and applying precise computer-controlled traction with patient-controlled stops. And because this approach is conservative and reversible, your body's response can be tested without committing you to something permanent. We also operate strictly within the limits established by CBP research, applying enough force to stimulate correction, but never enough to injure tissue. So I hope you can see now that you are not stuck between doing nothing and major surgery. There's a third option: a high-tech, non-surgical corrective care approach that gives you data-driven clarity, a realistic chance to stabilize the slip, and the confidence that you explored every reasonable option before making an irreversible decision. So the real question becomes simple: does this approach actually work in the real world, not just in theory? Because understanding a plan is one thing, seeing what happens when it's applied to a real person with a real anterolisthesis is what actually matters. One of our patients, a woman in her mid-50s, came in with severe anterolisthesis measuring 11 millimeters, along with leg weakness and difficulty walking. She was already being monitored and had been told surgery would likely be in her future. Traditional hands-on care was not enough for her case, so her care plan had to evolve. That's when the RoboTrack became critical. Using specialized traction specific to anterolisthesis correction, we were able to unload her spine in a controlled way that manual techniques could not safely achieve. As her symptoms improved, structural and neurological corrections were introduced. Follow-up x-rays showed a measurable reduction in her slip from 11 millimeters down to 6. Even more telling was her outcome. She avoided fusion surgery, remained active, and continued working instead of entering a long surgical recovery. Her neurologist later commented that this was the first time that he had seen an anterolisthesis reduction that was not surgical. That is the difference between managing symptoms and applying a measured, non-surgical corrective care plan. This is the kind of work we do at our clinic. I am one of only 3 advanced certified chiropractic doctors in Western Canada, and the only one using the RoboTrack system as part of a non-surgical corrective care approach. I hope this video helped you see that there are non-surgical options that truly target anterolisthesis with the goal of reducing and correcting the problem, not just masking pain or managing symptoms. When care is designed around measurement, structure, and neurological stability, it opens the door to real change instead of endless waiting. If you've got concerns about your spine and want to know whether chiropractic biophysics and RoboTrack are appropriate for you, the next step is finding a CBP or corrective care doctor in your area who uses the RoboTrack system. That combination matters because not all conservative care is designed for this level of correction. Now, if you're in the Kelowna, British Columbia area, you're welcome to come check us out. I would love to see how we might be able to help you. We regularly see patients who travel hours to receive this type of care, and some even come from out of province because these services are not widely available. If you got value from this video, please like it and share it with someone who may be struggling with anterolisthesis and feeling unsure about their options. That simple action helps this information reach people who need it. If you need help finding a CBP doctor in your city, leave a comment below and I will point you to an online directory of CBP doctors so you can explore your options locally. And remember to subscribe to the channel if you want to take control of your health and start moving without fear again. You will find practical, evidence-based videos on posture correction, spinal health, and keeping your body strong for life. Finally, if you want a deeper explanation and a full demonstration of how we correct anterolisthesis using the RoboTrack system, watch the next video. It walks through the process step by step so you can see exactly how this approach works.